Assalamu alaikum warahmatullahi wabarakatuh. Hello Journal Club listeners. Today we have a recent randomized double-blinded clinical trial that is published in the JOE in 2024, conducted by leading researchers in endodontic pain, including Fowler, Nustin, and a reader from The Ohio State University. They address a very relevant clinical question, which is combining ibuprofen with acetaminophen is actually superior for endodontic pain management? Although guidelines often recommend this combination, most of the evidence comes from the post-surgical, post-treatment models. And as we know that endodontic pain is biologically different from the post-treatment pain, it involves the bacterial byproducts, cytokines, and complex inflammatory and immunologic pathways, not just prostaglandin. This study, titled as Pain Reduction of Ibuprofen Sodium Dihydrate, which is a newer formulation of ibuprofen where it's more in its soluble phase and it has a fast absorption, fast acting property. And in combination with acetaminophen in an untreated endodontic pain model, a randomized double-blinded investigation. The study aimed to compare pain reduction of ibuprofen sodium dihydrate alone versus combined with acetaminophen in patients with acute untreated endodontic pain. They included 64 emergency patients diagnosed with symptomatic irreversible pyetus or necrosis, and most importantly are with symptomatic apical periodontitis. All patients reported moderate to severe pain. The pain was assessed using Heft-Parker, the VAS score, and recorded every 15 minutes for 4 hours prior to the treatment. For the randomization, each patient was assigned a random 6-digit number generated using a random number generator. These numbers corresponded to either the first group, which received the ibuprofen alone, and the second group was the combination between ibuprofen and acetaminophen. These allocation codes were provided to a pharmacist who prepared the medication and placed them into identical capsules and bottles. They ensured that both the patient and the investigator were blinded. The investigator was not present during the drug administration, and medications were given by a separate research associate. There's an important discussion point here, which is that this is not a placebo-controlled study. Instead, it's an active controlled trial where they used the ibuprofen group as the standard effective treatment, and the intervention is the combination between the ibuprofen and the acetaminophen. The reason why they use the ibuprofen as the control is because of the known effectiveness of this NSAID, and the authors here wanted to test if adding the acetaminophen would improve an already effective analgesic. So the outcome measures were the pain intensity over time and time to 3 points. First, the first pain relief, second, the meaningful relief, and third, the 50% pain reduction. For the results, both groups showed significant pain reduction up to 120 minutes, which equals to 2 hours. Then a plateau phase, which is when the pain level stayed almost the same and did not continue to decrease significantly. This is when the drug reaches its maximum effect. In this study, both treatment groups showed a similar pattern of pain reduction over time, with a noticeable decrease in pain reduction in the first 2 hours after the medication intake, followed by the stabilization, aka plateau phase. During this phase, the pain levels remained constant without further significant reduction. Importantly, there was no statistically significant difference between both groups, the patients who received the ibuprofen alone and those who received the combination with acetaminophen, across all the measured points, including the pain intensity and the time to pain relief. They concluded that adding the acetaminophen did not provide additional analgesic benefit over ibuprofen alone. In my opinion, a very important point to discuss here is that previous studies have been mainly based on the post-surgical and post-treatment pain models, suggesting that combining the ibuprofen with acetaminophen would improve the analgesic effectiveness, including that of Mahmoud Turabinjad in 1994, who supported the effectiveness of the NSAID in controlling the post-operative pain and contributed to the common assumption that combining analgesics would improve the pain control. However, more recent trials showed no added benefits of this combination, And the current study is important because they use the untreated endodontic pain model by eliminating the confounding effect of the pain reduction due to the treatment itself by removing the inflammatory source during the treatment. Unlike the post-operative models, the untreated endodontic pain model reflects a more complex inflammatory environment driven by the bacterial and immunological factors, which may alter the response to the analgesia. Finally, in my opinion, this study is clinically important because it challenges the common assumption that combining ibuprofen with acetaminophen is always superior for pain control. Instead, it suggests that in true endodontic pain conditions, the ibuprofen alone may be sufficient to achieve effective analgesia. And a major strength point of the study is that they used this untreated endodontic pain model to allow for proper evaluation of the drug's pharmacological effect. Final takeaway is that by using a true untreated endodontic pain model, it showed that the ibuprofen alone performed just as well as the combination, and it emphasizes that analgesic effectiveness is highly dependent on the pain model, and that most of the evidence from post-surgical and post-endodontic treatment cannot always be directly applied to endodontic pain. Thank you so much for listening. Hope you have a great day. Bye.